How's it going, guys? Difficult question for Immuno. I'm going to tell you exactly what you need to know for USMLE. Keep this hyper clean and simple, okay? You got this 6-year-old boy who has some sort of issue with TAP proteins. They ask this on the NBME exam. This is what you've got to know. 3 things. TAP proteins, beta-2 microglobulin, proteasome function. Those 3 things are required for MHC1 to present antigen on the cell surface, usually virus, to CD8 plus T cells, okay? Keep that in your mind for a second. At the same time, we've got 2 things I want you to memorize. Endocytic pathway / endosomes and release of invariant chain from an acidified endosome. Sounds really fucking obscure, I know, just stick with me here. Those 2 things are MHC2. That's required for MHC2 to present antigen on the cell surface to CD4 plus T cells, usually bacteria, okay? So here we're telling you TAP proteins are fucked up. We could have said beta-2 microglobulin is fucked up. We could have said proteasome function is fucked up. So we know we're dealing with MHC1, and MHC1 presents to CD8, MHC2, CD4. So if your MHC1 activity is decreased, your CD8 plus T cell activity is decreased. Now, USMLE really likes you to know that NK cells wake up when they see cells that have downregulated or defective MHC1. Sometimes viral infected cells or tumorigenic cells will have downregulated MHC1. So it's sort of a backup system where your cell-mediated immunity, your CD8 plus T cells, can't knock out those cells by interacting with MHC1s. The NK cells will wake up and kill those cells. So they can present this on USMLE by giving you some 10-line paragraph. They tell you MHC1 function is decreased, and they want to know plus or minus for different types of things that will change. And you'd have to say, well, it's a down arrow, it's a minus for CD8 plus activity, and it's an up arrow for NK cell activity. Okay, so that's what you got to know in this situation. They can also be creative. There's a drug called bortezomib, which is a proteasome inhibitor used for multiple myeloma. If you knock that out, you're going to do the same thing. You're going to increase NK cell activity. You're going to decrease CD8 plus T cell activity. There's another NBME question where they want you to know that drug increases apoptosis, because if you build up proteins in the cell because you can't use the proteasome, then you're going to cause intracellular disruption and you're going to trigger apoptosis. The wrong answer in that case is decreased ubiquitination. You'd actually have compensatory increased ubiquitination to try to override / get past the decreased proteasome function. So you got to be careful with that. Ubiquitin normally tagged to proteins to send them to the proteasome for breakdown. So let's just quickly look at the other answer choices. Choice A and B, CD4 T cell activity is wrong. That could have been correct had we have defective endosome / endocytic pathway function, or defective release of invariant chain from acidified endosome. Holy shit. Basophil response, neutrophil chemotaxis, garbage. Okay, so neutrophil chemotaxis, you could be aware, LTB4, interleukin 8, C5a, kallikrein, platelet activating factor, bacterial products, those are all stimulatory of neutrophilic chemotaxis. Decreased function of B cells, garbage answer choice, okay? That could be something like, if we're talking about cellular interactions here, defective CD40 ligand for hyper IgM syndrome, where the CD4 plus Th2 cell will have defective CD40L, can't trigger to CD40 on the surface of B cells to induce isotype class switching. Wrong fucking answer. Choice C, decreased neutrophil recruitment, garbage answer choice, wrong fucking answer, as I just harped on. If we're talking about neutrophil chemotaxis, we'd be dealing with LTB4, interleukin 8, C5a, kallikrein, platelet activating factor, bacterial products. Wrong fucking answer.